Okay. Hi, everyone. A very good evening to you all. Uh, this is the first webinar on operationalizing UHI in India. And I have with me my team members, Sajneet and Bhavani. And we also have Amod, who is the technical lead, who is for developing the UHI network, essentially. So we'll just start with the agenda for the call. And the agenda will essentially cover the introduction to the housekeeping rules first. And then we'll briefly go over the ABDM mission, and we will spend some time on the unpacking UHI and the elements of UHI part, right? And then post that, I think Bhavani will take you over the different parts of the UHI, where essentially we'll be breaking down the flows and we'll be talking separately about each of the flows that we have mentioned in the consultation paper and that we have sought your feedback on, right? And then at the last, we'll have the next steps on the call and how essentially you can submit your feedback and more details about the upcoming webinars and all. Right. So delving into the housekeeping rules, I think we're primarily relying on 3 rules here. And we all expect you to put your questions on chat if any time during the call you're having any doubts and questions, so that the flow of the presentation is not interrupted. And we can take that questions at the end of the session during the Q&A session, during which you can raise your hand if you want to ask your questions, and essentially we'll unmute you. You can unmute yourself and then ask your questions there, right? So essentially we'll be following a talking stick model for speaking, and we request you all to keep muted during the presentation. Okay, so I think we'll just start with the brief overview of the ABDM and the UHI journey. So essentially the ABDM was launched by the PM in the September of 2021, but it had been already undergoing a pilot in the 6 union territories and for more than 1 year, right? And during that phase, I think the consultation paper for the UHI was released in July 2021, where we sought feedback on how essentially the UHI should work and what should be the framework for UHI. Right? And post that, in Jan 2022, the NHA took lead in developing the gateway for UHI. So the gateway forms the heart of UHI, which essentially broadcasts and brings the interoperability into the system, right? So the gateway was developed in Jan 2021, and then we decided to take an approach similar to what UPI also did with the launch of the BHIM application. So we also decided to make some reference applications so as to give an indication to the markets that essentially this is how a UHI enabled application will look, and essentially how you can book an appointment and have the complete booking through the UHI network. So those applications were developed in the June 2022. And then we post that we also had a hackathon for UHI where more than 70 teams participated, and we had more than 200 people participating for the hackathon. And we received some very innovative solutions to the problems that we are seeking answers for in UHI. So the hackathon was conducted in July 2022. And post that, I think we were good with the gateway, but we decided to do an alpha testing for the UHI. So essentially, this was a closed group testing where we asked the participants to provide their feedback on how essentially the UHI enabled applications were working, and were there any enhancement that were needed in the network or the protocol as such. And November 2022 is the when we started engaging with other market players and the other government players there. And that is essentially the beta testing, and which has been undergoing since November 2022. So right now we have around 9 major platforms in India who are trying to integrate with UHI and who are making their applications UHI compliant. And in December 2022, this is the market rules consultation which we are having right now, which essentially is a major bedrock on how can we operationalize UHI. So far we have the tech aspects of the UHI ready, but for the market rules and the policies governing UHI, is that where we sought some feedback, and this is what the consultation is intended for. Moving on, briefly talking about the ABDM vision and the principles. So the ABDM lies on the vision of delivering quality healthcare to all the patients, and it delivering accessible, equitable, and standards-based digital health ecosystem. So essentially, the ABDM governing model is to ensure there's an interoperable and open network for digital health. It can be easily scaled and it is accessible to all. And the ABDM works on a decentralized architecture, right? So when I say decentralized architecture, I mean, essentially there is no central node for ABDM. The data doesn't reside with ABDM. It relies at the edges of the ABDM, right? So ABDM follows the decentralized architecture, and ABDM is following the principles of patient centricity, right? So patient is heart of the ABDM governing principles. And since ABDM uses the identities for all the participants who will be part of the ABDM network, it is transparent and secure in a way that everyone interacting on the network knows the other side of the party, who is essentially verified either from the patient side or from the provider side or from the facility side, right? So everyone operating on the ABDM ecosystem is essentially, their identities are known. So the system itself is transparent and secure. We'll spend some more time on this slide because essentially this is a complex looking slide, and I'll just and I think it will be helpful if we take the user journey into mind, user health journey into mind, essentially how a user completes his overall journey in a health ecosystem, right? So we'll start at the bottom of the slide, which essentially is the digital public goods, right? And here ABDM leverages the cross-domain digital public goods such as the Aadhaar, the UPIs, the e-sign, DigiLocker and all, which are essentially developed in India, and using those cross-domain digital public goods, providing identities to all the players in the health ecosystem, right? So the patients have a ABHA, essentially, which is the Ayushman Bharat health account, which enables them to access the ABDM ecosystem. The health professionals have a HPR, which is essentially the health professional registry, where they are verified on that. The healthcare facilities are registered on the HFR, which is healthcare facility registry. And there's a drug registry also based on the cross-domain leveraging the cross-domain digital public goods, right? So essentially leveraging those digital public goods, we are creating identities in the ABDM ecosystem, right? So let's say you are a patient and you try to book an appointment, right? So first you have to create an appointment, you have to create your identity on the ABDM ecosystem. So you create your ABHA, which is essentially an entry point into the ABDM ecosystem, right? Now you're trying to book a service. And these three in the bottom, three in the middle layer are essentially the three gateways that ABDM has. So we'll just take the your first interaction in mind, and where you're essentially booking the appointment, right? And for booking the appointment, you'll be using the UHI gateway, where you can access a variety of services ranging from the teleconsultation to physical appointment booking and diagnostic services and other services as well. So you'll be using the UHI gateway to essentially book a service. And to book that service, you have the patient side application, which is the end user applications, the EUAs, where the patient can come and book an appointment, right? And from the doctor side, you have a health service provider applications where the doctors can be, which are the doctor side facing applications where the doctor can provide their services, right? So you book your appointment, through the UHI gateway, right? And then when you're booking an appointment and once your appointment is booked, you want to share your records with the health professional, right? And that's where the health information exchange and the consent manager gateway comes in. The health information exchange and consent manager gateway is essentially dealing with the data, which is the health data, right? So it provides an interoperability for the health data where a patient can share the health records with the doctors when they have booked an appointment using UHI, right? And there are various apps that are currently in the market and which we call the personal health record apps, the PHR apps, right? Where the patient is able to access their health records. And on the other side, the doctor can link the health records of the patient through the HMIS or the LMIS, the lab management information system, right? So essentially the HICM forms the bedrock of sharing the records during the transaction, during the health service booking, right? So now you are a patient, you have booked your service, you have shared your records with the doctors as well, right? Now you are doing an appointment on the UHI gateway. You're doing an appointment through the end user application and the health service provider applications, and now you have shared the records. the doctor has received those records on their HMIS or the LMIS system, right? And they can see your record history and what are the diagnosis, whatever relevant diagnosis is for you, right? So now when your diagnosis and the entire booking is completed, now essentially the payment is required, right? And the payment essentially is facilitated by the health claim exchange gateway, which is the third gateway on the right side, right? The third gateway essentially provides standards for health claim exchange, right? So there are claim standard where once you submit your records and the insurance provider for you, or if you are a PMJY beneficiary, on behalf of the patient, the insurance provider or the PMJY can settle with the doctors on their behalf. So that's when essentially the health claim exchange gateway comes in, right? So we saw that the different gateways have different roles in the ABDM ecosystem. And on top of them, the applications right now might seem very differentiated, but eventually the goal is that all of these applications will be combined into, from the patient side, an end user application, and from the health service provider application, all of the HMIS related functionalities will be integrated into a single application, right? So essentially, this is the ABDM stack. And we covered all the major components of the ABDM stacks, starting from the registries to the gateways and the applications built on top of them. Moving forward, now we'll just delve more deeply into the Unified Health Interface, the UHI. So the major aims of UHI that it was developed for is to increase the discoverability of the healthcare providers, right? So a patient looking for a service fulfillment should be able to discover a host of doctors from where they can avail a service. It is also providing consumers with a verifiable providers, right? So all the provider on the UHI network essentially are HPR compliant, right? So their identities in the health ecosystem are established, and the pricing also is something that is mentioned on the UHI. When you try to transact on UHI, your pricing has to be mentioned, and it's something that is known to the patient directly when they are booking a service. For the provider side, it allows them easy monetization for their consultations, and currently the under monetized service, right? So the consultation where most of the doctors are having the first consultation, but teleconsultation is something that is a preferred mode for a second consultation or a follow-up appointment. So it allows the easy monetization of that. And it also building the middle layer or the main infrastructure for the health ecosystem. It's also trying to foster the innovation in the health sector, right? So currently the UHI is focusing on the main services that include our digital consultation, physical appointment booking, ambulance services, lab diagnostic services. But these are not limited to it. We're trying to expand the horizon of services under UHI, and we're currently looking into vaccines as something that can also be covered under the ambit of UHI, right? So essentially, the services will keep on expanding as the network keeps growing. And in turn, the value creation for all the stakeholders in the healthcare ecosystem. So how the UHI tries to do that. So that the different stakeholders that are involved in the healthcare ecosystem currently, the citizens, the doctors, the labs, and the health tech startup, right? So essentially for the citizens, UHI is providing them easier accessibility to healthcare, a wider choice of providers at competing prices, and they have the complete control over data. So which essentially means that the data is shared with their consent, right? No one can access their data without their consent. For the doctors and hospitals, allows the easy discoverability of the patients and the fast ramp up of their practice. So once they come onto the UHI network, essentially they are discoverable by all the patients on the network, right? And also using the ABDM framework, they can also access the history of the patient, and essentially that will make the diagnosis much more accurate, right? Similarly, for the diagnostic labs, they are easily discoverable over the network. It will facilitate the increased footfalls and the ease of reporting back the results to the patient, essentially linking to their ABHA accounts, right? And for the health tech startups, it's building that layer and building that infrastructure which the health tech startups can leverage to essentially grow and to scale. So they don't have to take care of the essentially the verification part of the healthcare providers, which is essentially taken care by the ABDM ecosystem, right? And leveraging that common public platform, they can increase their business revenues and make innovative choices to essentially make their adoption of the product faster. Right. So now, delving much more deeper into the UHI, essentially, we will be talking about how the current health service infrastructure looks, right? And it's currently very siloed. So if you are on a health service application that you are using, essentially the doctors that are accessible to you are the doctors of that particular application. So just to take an example from private sector, essentially, if you're using a Practo application, and you are a user of Practo application, you try to use the app, all the health service provider side on the other side are only who have been onboarded by Practo, right? So this is very siloed approach where the platform is the center which matches the demand and supply for the services, right? So essentially here the platforms are matching all the health apps that are currently existing in the health ecosystem. They are matching the demand and supply. What UHI tries to move towards is essentially building that middle layer, which you see an intermesh of network, which essentially provides that middle layer, which allows all the user platforms to connect with the provider platforms on the other side, right? So maybe you can be a user of a Practo app, but if you want to book an appointment or if you want to discover a doctor on, let's say, a eSanjeevani or a ORS, which are the government side platforms, you can do that easily through the UHI network. So the provider platforms comes from the platforms are the one who are providing you the service, and the user using any user platform can essentially access that service. So now that the platforms are essentially not the arbiters of matching the demand and supply. The network itself determines the demand and supply, right? And our user looking for any service over the network can access all the providers from the other side. Similarly, for the providers, any user who is on a different app as well can discover them when they are on the UHI network. So there are essentially 4 major components of UHI, and these include the patient side applications, which we are calling the end user applications, and their main role is to acquire the users, right? They are the patient side applications, and the more user friendly experience that they provide to the user, the more will be their adoption, right? And essentially, they will be also the generating the orders for the health service provider applications as well, right? And in between them, we have the UHI gateway, which essentially does the role of routing the requests which are coming from the patient side applications, and it also collects the metric which maintains the network health, right? So these are the major tasks of the UHI gateway. So essentially, routing of the request and broadcasting of the request that is coming from the end user side. The UHI gateway itself uses that gateway registry, which is nothing but a registry for the provider side platform, the user side platforms. So essentially, whenever a platform wants to become a part of the UHI, they onboard onto the gateway registry. So their identity is established by the network registry, and it also provides the platforms with the keys to access the network. So the public and private keys using which they will be facilitating a transaction is also the role of the gateway registry, which essentially stores these keys and validates whether the request is coming from a valid participant on the UHI network, right? So we covered the end user application, which are the patient side application, the gateway, which is broadcasting the request that is coming from the end user application. And on the other side of the supply side, we have the health service provider applications, which are nothing but the doctor facing applications, right? So whenever a booking request is generated from the end user applications through the UHI gateway, the health service providers get to know that there is a request for their service, and essentially the health service provider applications are playing the role of acquiring the orders. They'll be providing a user-friendly experience to the service providers. Essentially, these can include a variety of services which can improve their experience in terms of accessing the patients or accessing the history of the patients. And essentially the fulfillment of service through various modes. These can be the teleconsultation, which has the video mode, or the physical consultation appointment booking, which is essentially you go to the hospital to fulfill your needs. Now we'll be covering the major elements of UHI, and let my team member Bhavani take over. Bhavani, over to you.
Hey everyone, thank you Pankaj for the introduction. So we'll now go over to the elements of UHI. The first one is search and discovery. So when a user searches for a service on any end user application, which is a patient side application of their choice, so the search, they can do a search by service or by symptom or facility or specialty. So once the user searches on the end user application, the end user application, or the EUA as we call it, forwards the request to the gateway. Then the gateway does a verification process with the UHI registry. I'll come to this in a little bit. And after the verification, it broadcasts the search to the HSPAs, all the HSPAs that are relevant. And once the HSPA gets a request, they can choose if they want to respond to it. And if they do want to respond, they can respond with the doctor details and the price. And the request is sent back to the response is sent back to the gateway, and the gateway relays all the responses to the EUA, and the EUA shows it to the user. So that is a simple search and discovery process. So the role of UHI registry here is twofold. One is the verification. So UHI registry has all the EUAs and HSPAs that participate on the network have to register in the UHI registry. So when a request comes, the gateway checks if the entity that is sending the request is a part of the UHI registry. And similarly, the HSPA that's responding to a request is a part of the UHI registry. So this is to ensure authentic entities on both sides are participating in the transaction. The second role of the UHI registry is to route the request to only relevant HSPAs. So what I mean by relevant is, for instance, as when an HSPA becomes a part of the UHI registry, they also declare what services they provide and what cities they want to service in. This is to ensure that, for example, an HSPA that provides an ambulance service in Bangalore does not get a request for, say, a teleconsultation in Delhi. So to enable this intelligent routing, that's why the HSPAs also declare the services and the cities. And when the gateway is forwarding the request to the HSPAs, it identifies which HSPAs are relevant for this particular request and sends it to only them. So that is the purpose of the UHI registry here. If you go on to the next slide. So the first part is intelligent routing that we just talked about. And the second part is to prevent preferential treatment. So the market guidelines have different sort of guidelines in place to prevent any kind of preferential treatment. So the first one is it clearly defines the roles of HSPA, EUA, and gateway. For instance, all the HSPAs will be required to accurately provide accurate and complete information about the services they're providing, the doctor details, and all of that. The gateway will be required to relay all the requests, all the responses they get to the EUAs without any personal bias or discretion. And similarly, EUA will be required to show all the requests that it gets from the gateway to the user without any kind of filtering. So now coming to the second bit, where an EUA, if an EUA, for example, which is an end user application, has also some doctors on its platform, but it's onboarded only as an EUA. So for example, I can book appointment on, say, app ABC, but my app ABC also has a few doctors that are not a part of the UHI network. In that sort of a scenario, the EUA cannot, if a request comes from a user, the EUA cannot send the request to only the closed group of HSP or closed group of doctors I have. If it wants to send it to the closed group of doctors, it has to also send it to the gateway. It can't just send to its own closed group of doctors. And when the responses come from the gateway, like all the HSPAs who have responded, and its own closed group of doctors have also responded, it also cannot prioritize the results from its own closed group. It has to treat the HSPs. HSPs are health service providers, which are essentially the doctors. It cannot treat doctors from its closed group as like priority. It has to treat both of them on the same level. Now, this is for the time being, but eventually, all the EUAs that have a closed group of doctors will have to come on board as an HSPA and make those closed group of doctors part of the network by coming as an HSPA and bringing those doctors also onto the UHI network. We go to the next slide. The third is around the guidelines around ranking of results by EUA. So once the gateway sends all the responses to the EUA, which is the patient side application, there is no specific mandate that the NHA mandates about how you should show the landing page, how the ranking should be there. All the market guidelines say is that whatever ranking that you display, you have to also show the parameters used for that ranking. For example, if an EUA decides to display the landing page by distance or by proximity or by price, it has to have a toggle or something that shows how exactly the landing page is being sorted, and also provide an option for the users to also sort it around according to the kind of preference they have. Also talking about if an EUA wants provides an option for the HSPAs to rank their particular results, they can do so, but any promoted ranking should be shown very clearly for the user as promoted, so the user knows that a particular ranking is there because it's being promoted, and that is on the user side. And also the EUA has to have clear and transparent policies on how any HSPA can promote their ranking and publish that, so that there's there's transparency in that process as well. When we talk about the regulation of monopolies, so we have been getting a lot of market concern around whether monopolies can come on board and then create entry barriers and prevent the local companies or the smaller companies to prosper. So this is something that we have taken into cognizance, and there's also a question in the consultation about what is the best way to regulate monopolies, but not also hamper growth and incentives for this. This is something that we want response from you as well. So coming to service booking, so the service search and discovery, and the process ends with the user being able to see a list of services that's available for them to book. So when the service booking happens, once the user has seen, like there are about 5-6 doctors or more, they select a particular service or a particular doctor, and the EUA relays that selected service to the HSPA, and in communication with the HSPA, fetches the details about price, availability, the calendar, slots, and shows it back to the user. So here there are two important considerations. One is that the role of the gateway is only search and discovery. So at the previous step, the gateway broadcasts the search, and in that broadcasting, it also establishes a connect. So after all the steps that follow after search and discovery happen directly between the EU and HSPA. The gateway has no role to play there. And the second important consideration, you can go to the next slide, is the transaction level contract. So as a part of the service booking, when the user confirms a booking, the transacting EU and HSPA get into a transaction level contract, which has details pertaining to the order details, the terms of booking, the cancellation and reschedule terms, and all of those. And this contract is a digitally coded contract, and it's signed by both the parties. And this is binding in the sense any violation of these terms can be a grounds for raising a grievance in the grievance redressal mechanism. The third bit is accuracy and transparency. So the market guidelines require the HSPAs to have clear and transparent policies on refund, around cancellation, rescheduling, no-show, and any other sort of situations. The NHA does not provide a template or mandate a template on how these terms should look. It only mandates that the terms should be present and it should be prominently displayed to the user. Yeah, if you go to the next. So once the service booking is done, once the user has booked the service, then comes the service fulfillment. So whatever was decided upon at the time of service booking, the payment terms, the availability, all of those terms that was communicated, the HSPs or like the doctor's responsibility is to deliver the service as per the terms that was shared with the user during the booking. In case there is any reschedule, cancellation, no-show, the refund and the processes will take place according to the terms of the booking. And like I mentioned earlier, these terms are binding in the sense any violation of these terms can be a grounds for raising grievance using in the grievance redressal mechanism of the UHI network. So that's the supplement. Coming to payment and settlement. So here there are two flows. The flows are identical in nature with only a slight change. In figure A, which is the left-hand side figure, the EOA or the patient side application collects the payment. And in figure B, the HSPA collects the payment. So let's focus on figure A, and I'll explain how this works, and then I'll come to the figure B. So before I go to the flow, there are two new terms that I'd like to kind of go over first. The first is settlement agency. So settlement agency is nothing but the collector's bank account or RBI regulated body that performs the settlement. So when I say collector, I mean EUA because we're focusing on figure A. And it's also important to understand that in both the figures, the entity that collects the payment is also the entity that settles the payment. So the collector is also the one settling. So settlement agency here in figure A is, in simple terms, for example, is EUA's bank account or any other RBI regulated body that performs the settlement. The reconciliation service provider or the RSP is any entity that can be in-house or a third-party entity, which prepares something called a settlement advice. So if it's an in-house entity, it could be as simple as EUA's finance division. So in EUA's finance division, they look at, for example, they look at the audit details, the transaction level contract, and look at all of those things and decide and come up with a settlement advice, which means how much of the amount has to go to the EU and how much of the amount has to go to the HSPA. They look at that and they prepare the settlement advice in a way that it's consumable by the settlement agency. Now I'll just go over the flow and maybe this will become clearer then. So when a user pays an amount and has gotten the service, has availed the service and makes the payment, the EUA collects the payment. Then the payment is held in a nodal-like account till the settlement process is completed, so that that amount cannot be used for some other purpose in the meantime till it's settled with the HSPA. So user makes a payment, the money is held in the nodal-like account. Then for sake of simplicity, I'm using examples. Then a RSP, which is say EUA's finance division, looks at the money that's been received, looks at the transaction level contract, the audit details, and any other relevant bank information, and creates a settlement advice saying, okay, this much goes to the EUA, this much goes to the HSPA. Then that is sent to the settlement agency, which is, for example, EUA's bank account. And the settlement agency, upon direction by the EUA, it makes the settlement and makes the payment to the HSPA's bank account. Then the HSPA will settle it with the receiver, which is the doctor, but that happens outside the network. Like how the HSPA settles with the doctor, whether it's in a weekly basis, monthly basis, daily, that is according to the terms between the doctor and the HSPA, and that happens outside the network. So this is the process of the payment and settlement. If you just look at the figure B, it is exactly the same. Just the only difference is that the HSPA collects the payment. So how this happens is the HSPA, which is the doctor side application, sends a payment link, sends their own payment link to the EUA, and EUA shows it to the user. And the reason it has to come through EUA is because EUA is the patient side application, and a user only interacts with an EUA. So if the HSPA sends the payment link to the user, to the EUA, and user uses that payment link to make the payment, then the amount is going to the HSPA because it's the HSPA's payment link. So the HSPA gets the money. They put it, again, it goes to a nodal-like account, and it's being held there, while the HSPA's reconciliation service provider, which is say HSPA's in-house or outsourced entity, prepares a settlement advice, shares it with the HSPA's bank account or any other RBI regulated body. And upon direction by the HSPA, the bank or the body makes the payment to the EUA and the amount is settled. So the process is exactly the same, just that on figure A is EUA and figure B is HSPA. So I hope this is clear. Any questions about this? I'm happy to answer at the end of the webinar. We go to the next thing. So the reason we have two proposed payment flows is because given the complexities, the NHA seeks to mandate for the time being that only one of the network participants, either the HSPAs or the EUAs, collect and settle the amount. So either we say EUAs collect the settle, all EUAs will collect and settle the payments, or all HSPAs will collect and settle the payment. One of the questions for the consultation also is what are the pros and cons of say EUA collecting or in HSPA collecting, which would make more sense for the time being. And that's why we put two flows as well. And this is somewhere we could use your input as well. But in both the cases, the one collecting will also be the one settling. And whichever entity is the one that is collecting and settling will also be required to maintain a nodal-like account to transact on the UHI network. Coming to the rescheduling and cancellation. So this is again as part of what we went through during the service booking. It's a responsibility of HSPAs to provide clear and comprehensive rescheduling and cancellation policies, which are communicated to the EUA and for the benefit of the user at the time of service booking and confirmation itself. Any refunds or any other rescheduling cancellation processes will be processed based on those terms. And NHA does not prescribe a template or mandate any particular cancellation or rescheduling timeline. It only requires HSPS to have transparent policies in place so that a user is not inconvenienced. The role of, again, the rescheduling and cancellation terms are also digitally coded into the transaction level contract, which is executed through protocols. So that's also for the easy implementation of these. Coming to grievance redressal. So here, this is a flow that I'll go through and then also explain as I go. And if there are any questions, I'll take later. So when a complainant raises an issue, so here a complainant can either be a patient or a doctor. So if a complainant is a patient, if a patient raises an issue, then the interfacing app for the patient is the end user application. If the complainant is a doctor, then their interfacing app becomes the health service provider application. So consider the case that a user, like a patient, raises an issue. So when a patient raises an issue, the interfacing app, which is the EUA's internal, it is first, it first goes to the EUA's internal grievance redressal mechanism. So for example, the EUA can have FAQs or a chatbot or an online customer portal or a customer care number, or even like a physical office where they can deal with complaints. So that is the first stop for the grievance redressal, where as a patient, I'll go to my interfacing applications, which is my EUA's grievance redressal page, and see if there's any recourse there that can address my grievance. In case it doesn't address my grievance, then it's escalated to my EUA's grievance redressal officer, who will evaluate the issue. So the grievance redressal officer or the GRO will evaluate the issue to see if the grievance raised falls under my purview or not. Does it fall under the EUA's purview? If it is falling under the EUA's purview, it will be sent to the relevant team and the resolution process will start. In case it does not fall under my purview, then the grievance is forwarded to the counterpart app's GRO. So if I'm a user and EUA's GRO decides that it does not fall under my purview, it will go to the HSPA's GRO. So the HSPA's GRO will also do a similar process. We'll again check if this is something that is falling under the HSPA's purview. If it is falling there, then the resolution process will start and the issue will be resolved. In case the HSPA's GRO also decides it does not come under their purview, then it will be escalated to the online dispute resolution mechanism, which is includes stuff like mediation and arbitration, negotiation, all of those. In case that works and the issue is resolved, then that is the end of the process. In case it's not, then the complainant is free to use other legal remedies available to them. So like I've mentioned, so there's internal grievance redressal mechanism, which is the FAQs, chatbots, anything of the interfacing application. If that doesn't work, then it goes to the GRO. The interfacing GRO first checks in case it falls under their purview. If it does not, the HSPA's GRO or the counterpart's GRO sees if it falls under their purview. If neither of them claim responsibility or the user is not satisfied with any of the resolutions given, then it goes through the ODR mechanism and then the other legal remedies. Okay, now there are a few more miscellaneous elements. First is the metrics. So the participating EUAs and HSPAs will be required to share a set of anonymized aggregated metrics to help monitor fulfillment and gain service insights, as well as to contribute to larger health data sets, and also to track the growth of the UHI network. And these metrics are still under development. And this is also a question in the consultation as well, about what kind of metrics can be collected. Coming to the next one, which is common taxonomy. So NHA is looking to publish a common taxonomy, which is essentially a common language that all the transacting network participants can adopt to easily talk to each other and enable interoperability. And this is again something that is under development and will be released soon. Coming to scoring, there was also a question about this earlier, that as of now, NHA is not providing any sort of scoring or rating mechanism. But in the meantime, and the network participants are free to create and implement a scoring mechanism of their own in compliance with the law of the land. But as of now, NHA is not looking to publish a rating system. I think this brings us to the end of the webinar. We'll just quickly go over the next steps as well, and then we'll open this for Q&A. So everyone who's interested in providing feedback on the consultation paper can provide it on the link. We'll just share the link on the chat as well. The consultation is open till 13 January, and we'll also be holding another webinar on 6 January for those who want to, for those who missed this or want to go over it again.
That's all we had for today. Thank you everyone for joining, and we'll keep the next 20 minutes for questions. I have been responding to a lot of questions on chat already, but if there are any questions, I would request all participants who have a question to raise their hand. I will call you out and take the question then.
Excuse me, ma'am.
Yes, Dr. Nilesh.
Yeah, I had written my questions in a question and answer also. Actually, what I understand so far is that everything is in position as far as the patient is there, and acts are there are multiple Arogya Setu and all these things. And gateway you have nicely built in a form of UHA, and registries are going on. But the main thing is that what about the health service provider application? That is the main thing, because this is so far seem to be a one-sided traffic going on, and a picture is good, but audience how enter the show is the main thing. My point is that I try to summarize in which way I ask a question, so that should be to the point. But the main thing is that suppose I have a hospital and I have done the HFR also, and I have a HSAP application also with me for the video consultation. What is the next step for me? This is, but I feel that the specific question can be.
Sure. So Dr. Naresh, like we have published APIs and technical specifications for patient applications, we have also published the same specifications for hospital side applications, which are either doctor applications or HMIS players. So on the hospital or the provider side, there can be two types of participants. We can have aggregator apps such as Practo or MediBuddy, who essentially onboard doctors individually. Or we can also have an HMIS player who wants to play the role of an HSP. So similarly, similar to all the protocols and the APIs that have been published for patient-side applications, while we have built the gateway, we have also published the same for the provider-side applications. That is one. Second, NHA is also in the process of building a lightweight and free HMIS solution for all small clinics and providers. And this will be available very soon for all and clinics and health providers to operate, which will be ABDM compliant. So it will allow doctors and providers to create their HPR ID, create their HFR. It will also allow them to be available through teleconsultations via UHI. So it is already UHI integrated. So that is also something that is in the works and will be published, because we understand that there have been certain adoption challenges and certain challenges on getting that technical adoption to happen on the provider side. So there are lots of efforts that we've been doing at NHA's end as well to ease that process. One, of course, is publishing applications, and B is also creating a platform that would be both ABDM and, when we say ABDM, UHI compliant as well.
Madam, my supplement question to this is that after having a HFR, I have a HFR, but I do not have a software which is ABDM certified. But I have a software which is non-ABDM certified from the last 7 years. And HSP is provided by that service also. Now I can participate in UHI.
Naresh, you can participate in UHI, but what will happen is that if you are not a part of HPR, for example, if you do not have, if the doctors do not have an HPR, they will not be a verified doctor on the platform. So there, on the patient side applications, there will be a clear distinction on those, for those platforms, for those providers or health service providers who have an HPR and therefore are verified, and those who don't have.
Excuse me, ma'am. Excuse me, my question is not about HPR.
Sure.
Because professional, I am verified and my hospital is verified. Actually, thing is that the real-time consultation I have to give from
Right.
doctor's side through your platform to the patient.
Right.
Okay. And
So,
whatever about my application, which is non-ABDM compliant, firstly, which hasn't put into the UHI sandbox,
right.
and the majority of 80 to 90% is a such situation. This is my question, that, or we can say that I have to put my HSP into UHI sandbox or not.
Right. So you will have to put your HSP on the UHI sandbox to be able to give consultations. However, right now it is not mandated for you to be ABDM compliant. So you do not have to have M2, M3 done. You do not need to necessarily have a way to link health records back to the ABHA number. If you are UHI compliant and you enter the UHI sandbox, you will be able to provide services, offer teleconsultations, offer other services via the UHI network. So currently it's not mandated to be ABDM certified. However, we are recommending all doctors and hospitals to have.
Sorry to interrupt, madam. I today tried to register my HSPA on this UHI sandbox. Right. And when I try to submit, it automatically click HIU, which is the M3, which is the M3.
We understood your concern. In the interest of time, we'll let some other participants also take up the question.
Okay.
Have your email ID, and we will reach out to you directly to resolve this. Yeah.
Okay. Thank you. Thank you.
Can we
Hello.
have?
Am I audible? Oh, hello.
Yeah, nice. You're not audible. Can you?
Yeah, am I audible, sir?
Yes.
Hello?
Yes, you're audible now.
Thing is, I just wanted to know, is there any mechanism in UHI for referring a patient from one hospital to another hospital? For example, a patient in an emergency from hospital A is being shifted to hospital B. Now, on the transit, the hospital B better gets all the what all has happened in the hospital A, so it becomes easy for them to take over the patient. In UHI, do you have any such a mechanism there inbuilt?
Right. So there are two things, right? UHI focuses on the service part. I think the use case that you're referring to is how health data can be transferred. So their prescription can
not only that, the other hospital should be made alarm. They should come to know that the hospital, when hospital A is shifting patient to us, that part should come to know, and to which doctor it should go, that also should come to know. The message should follow, and they should ramp up. For example, suppose an MI patient is being shifted, they need to arrange for angioplasty immediately there. It should happen in minutes. So that hospital should come to know what all. So in such an event, is there a mechanism inbuilt in UHI, or should they only use traditionally phone call and all that?
Right.
It will be nice if it's inbuilt.
Yeah, currently there isn't a referral mechanism. However, each and every patient on the UHI network is identifiable and uniquely identifiable by the ABHA number. So all a user's past history will be available to different HSPA, different providers, different hospitals because of the ABHA number. However, there isn't a referral mechanism, and we request you to share that feedback via the feedback form on the chat, and we'd be happy to take that into consideration.
One more thing, I have some concern regarding ABA. The patients, the many patients don't have smartphone. They have a small this ordinary phone. Of course, they can share their OTP and we can register their patient. So the same patient comes to some other hospital. That hospital wants to use HIU service. If that patient doesn't have a smartphone, how he is going to give the consent? Acceptance, granting the consent, because he's using an ordinary phone. Without that PHR app, that patient cannot allow his health data to be shared to the other hospital. This is the one thing I never understood, how the non-smartphone users are going to give the data to other hospital.
Right. So currently the networks have been built for mobile first. So
Yeah.
and we're focusing for the purpose of this webinar on UHI. So I understand your concern, but that is in the context of health data exchange. So I would request you to take this up offline with us.
Yeah, this is was concerned with UHI because in emergency the patient may not even bring the phone also. So in such an event, the doctor should be able to access the data on emergency basis. Such a stringent restriction on access for the doctors to access the patient data can cost patient's life. So there should be some override mechanisms for the doctors and access the data, maybe by taking a oral consent or something. That facility doctor should have in emergency situation. Otherwise, patient will suffer. They may not be having the carrying the smartphone. Many times it happens. That's what we need. Doctors need this emergency override to access the patient data. They will require it. Maybe they can give some.
Share that feedback on the feedback form of the
Yeah.
consultation paper.
Yeah.
Thank you. Shashwat.
Yes, hi, hello. So I think one question you already answered regarding the situation where the EUI and the HSPA is the same entity. So the payment is something that I'll definitely post on the feedback form. But I had a a related question around it, where you did talk about grievance redressal officers. So in that in this similar situation where the EOA and the HSPA is the same entity, how would they need two grievance GROs, or will it directly be escalated to to the NHA?
So Shashwat, I think it will depend on how the organization is also structured, right? Is it one organization with the, or does it actually have two separate entities that operate differently? So this is something that will need to be decided by the organization. There will be protocols that will be published, and the organization can decide whether they need to implement the protocols both for the EUA as well as the HSPA, or they can manage the grievances by implementing one protocol. Since this is something which is still in the works, the grievance protocol is still worked on. So I would request you to also share this question on the feedback form if it's not addressed, if you're not completely satisfied with the answer.
Sure, thanks.
Okay. Next we have Rahul. Yeah, Rahul.
Hi, ma'am. It's Rahul. So we are working as a startup. I'm asking the one question: what about the HSPA or health provider having some subscription plan revenue model or different type of revenue model? How it will fit with the UHI? Is that anything?
Yeah. So the revenue model, both for patient side applications and the health service provider applications, is completely up to the application itself, and the organizations have the full freedom to decide what revenue model they want to operate with. The reason why we also have a settlement and payment and settlement protocol in place is because we understand that each application, each organization on both the patient side and the provider side might have their own service fee that they will be charging. And therefore, there will need to be a settlement that needs to be done across the participants. So there is no regulation on models and the business models that EUAs or HSPAs want to follow. There are guidelines around fair practices and fair pricing being shared across the network. However, there is no regulation on the models just yet.
So one more thing, and the gateway can like not bias, it can give the all doctors, those are registered on UHI. So what about they have created some business plan for particular segment of doctors, but the end user can see everyone. So if they are providing some subscription for some segment people, but that their subscription plan is not for all across the doctors or other people, then how we can do things.
So if the HSPA decides that they do not want to have all their services on the UHI network, that's the decision of the HSPA. The only thing that we have proposed in the market rules right now is that if the EUA, which is the patient side application, if they have a closed group of doctors as well, they are not allowed to exclusively send that request to that closed group of doctors outside the UHI gateway. They have to send the request to both the UHI gateway as well as to their closed group of doctors to start with. And eventually, those closed group of doctors will also have to be onboarded on the UHI on an application which is on the UHI network. However, on the health service provider side, if there is any service that the health service provider does not want to onboard UHI with, that is to the discretion of the HSPA. So HSPAs are not mandated to have all their services on the UHI network. They can choose what service they wish to offer on the UHI network.
Okay, thank you. Thank you.
Ashutosh, there's a question on prescriptions and sharing prescriptions. So there are two mechanisms in which the doctors can share prescriptions with patients. The first is via chat protocol, and there is a message protocol that has also been released as a part of our UHI network protocol. So that is one. Second, if the health service provider application, which is the HSPA, is also integrated with the HICM gateway, which is the gateway that allows for the exchange of health data, they can essentially link the prescription with a patient's Aadhaar and will be able to view that prescription on their PHR, which is their public health record app. So there are two mechanisms. As of now, we're not mandating that the prescription be shared via the HICM gateway, but there are plans that eventually we would want prescriptions to be shared via the HICM gateway to ensure that we are maintaining longitudinal health records for patients. There is a chat functionality and a message protocol that is also provided as a part of the UHI network APIs that allows for sharing of messages and sharing of files. Are there any questions, any other questions that I have not answered yet? Please feel free to raise your hand and I will address those questions. Yeah, Nikhil, please go ahead.
Sajnik, yeah. So just had this question that we have a lot of historical health records of patients on the platform. Is there one quick way of getting them ABDM compliant?
You have a lot of health professionals?
No, healthcare records, prescriptions and records of patients who have secured it on our app.
Right.
So instead of getting the henceforth data, how do we get the historical data ABDM compliant?
Amod, if I will redirect this question to my technical team. So Amod, can you take this up?
Ma'am, one more question.
Rahul, could you repeat that question, please?
Yeah, Nikhil, can we have a question
Yeah,
first?
yeah.
Rahul,
Sure. So how do we get the historical patient healthcare data that we have on our platform as of date, added to the healthcare repo, the whatever we call the DigiLocker for the patient instantly? Like it cannot be one by one record. So is there a provision for that?
No, so that part will be handled by the another development block, that is the HICM. Okay. So basically, all the record linking happens to HICM, which you can integrate with your EUA or HSPA. So that is something which is one of the components of ABDM. It would be kind of a service provided to the UHI users once you are done with M1, M2, M3.
Okay. All right. So as of now, there's no known way for this.
So let me just go a step back. So UHI is more of a discovery thing, and providing the services from a patient to a doctor, right? Sorry, doctor to a patient, and all these peripheral services which ABDM currently already has. Okay, these will be integrated with the EU and HSPA. So it is already there. HICM, we are also working on the health locker integration, where you have your records in a fire bundle or say in some kind of documentation which you can pull easily and push it to the doctor whenever needed with the consent.
Okay.
One more question I have regarding the payment. What about the sum of the payment happening through the offline? How the UHI can update this information on the platform?
Okay.
So Rahul,
Yeah, go on.
So essentially, the payment and settlement protocol allows for whoever is collecting to be the one who's settling, right? So
Yeah.
there is a mechanism through the settlement protocol where the collector notifies that they have received the payment, right? So that is done both either via the payment gateway or any online mechanism or an offline mechanism.
Okay.
So the collector will essentially notify that the payment has been made or has been collected, and then that's when they will start the settlement process.
Okay. Okay. Thank you.
Hello.
Yeah, Mr. Kapil, please go ahead.
Yeah. So I have one question. Let's say if end user application is having some incentive for patient, and they have their own set of doctor. So is there any guidelines in that? Let's say if patient is choosing only those set of doctors.
You mean those set of doctors who are not a part of any other application on the UHI gateway?
Yes.
Yes. So there are two guidelines currently which have been proposed to regulate this. If the EUA has certain doctors, a closed group of doctors which are outside the UHI network, they cannot send the request, any search request for a service exclusively to those group of doctors. The request has to be shared both with the gateway as well as those closed group of doctors. That is to start with. And any response that they get, the EUA cannot have any biased response from the closed group of doctors. They will have to response that they get from other health service provider applications as well as those closed group of doctors in the same fair manner. That's to start with. Eventually, it is proposed that we mandate all closed group of doctors to also be a part of an application that is registered on the UHI network to ensure fairness through the search process.
But let's say if they are giving some incentives to those closed group of doctors, so patient can patient can use that, right? Is it any issue? Will it be any issue?
Yeah, so you cannot prioritize those doctors. So if they are giving an incentive, you can have that response come back to the end user application, but that cannot be prioritized over other responses.
Okay.
Yeah. Ayushi, I will address some of your questions. Currently, the chat functionality is available only in English. However, the APIs that have been published in the chat functionality, essentially the mandate of what languages they want to have the chat in is the mandate of the EUA and the HSP. So they can decide, and therefore the innovation is left on their end, and they can decide whatever languages they want to have the chat functionality in. So the API essentially has been released, which establishes a connection between the EUA and HSPA, but it's up to them which languages that they want to understand. They want to keep the chat functionalities in. If there is any other question. Yeah, Ayushi, please go ahead.
Yeah, I have a follow-up which I've written on the chat. And my follow-up is that if the patient is illiterate or functionally illiterate, which are many of our population, they will not understand the prescription which is shared via platform in English or chat in the English language. So you have said rightly that it's on the platform providers who register onto the gateway to give the multilingual support. But the thing comes that a lot of the interaction would be happening on those multilingual platforms, or maybe via audio, which usually happens in teleconsultation and other modes also. The things become informal. And since we are talking about longitudinal record and other guidelines are also part of this. So is there any guideline? I'm not asking about functionality. Is there any guideline to maintain the audit trail of that? And would the platform be tracking or gateway be tracking that something went away from the platform or via API or technology platforms track that this there was a part where conversation didn't happen via the written mode, but it happened via any other modality between the doctor and the patient, any other facility provider. And
Right.
again, the follow-up is that the audio logs and other things, are they kept in the locker or they'll kept outside the patient record? Because it's not the Western context where we can have a complete record in English language. It's a context of India where a lot of things are verbal. Also, we can force doctor to do this, but I want to understand the perspective of the team who is building that. What do you think about that?
Right. So actually, like we said, the UHI gateway, which is what we're focusing on in this webinar, focuses on the health service part. The exchange of health data and the exchange of prescriptions actually happens via another building block in energy, which is not something that we're covering today. So I would request you to take this up offline. We're trying to limit the conversation today to UHI, which focuses on the services, the service layer for between patients and doctors. Between patient and doctors, and not essentially. So we can connect with you offline to take this up. Yeah. Great. I know we're over time as well. So we will conclude the webinar since there are no other questions. We request everyone to share their valuable feedback on the feedback form. It has been shared on the chat, and Bhavani will share it again on the chat. It's also available on our website. It's available on our social channels. Thank you all for joining this. This was super valuable, and we hope to stay connected with all of you for your valuable inputs and to develop and operationalize UHI together. Thank you, everyone.
Thank you.